So we're talking about the lungs. I like to say, when in doubt, take out. Okay? Think about the lungs, think about what they do. We talked about the alveolus earlier, gas exchange. Okay? So that is their job. That's what they're supposed to do. When they're not working properly, okay, the body is going to go into distress mode. Okay? The patient's going to have rapid respiration because they're trying to get what? More oxygen in. Okay? You're going to check the mucosa. Okay? Because if their oxygen is decreased, their lips might be blue, capillary refill is not going to be less than 3 seconds. You might see some bluing on the nail beds. Okay? Hypoxemia. Okay? So again, let's look at this picture I'm getting ready to show you. This is a Dorflex collection chamber. Now, what happens if a patient has, let's say, a PE fluid around their pleural cavity? The doctor may go in and put in a chest tube. So, the chest tube that's connected to the patient, you can connect it to this drainage system. Okay? Now, can you all see my cursor on the screen?
Oh, yeah.
You can?
Yep.
So, when you look at this section, this is the suction control chamber. The doctor orders how much suction that will be down on this container. Okay? Now, a syringe comes with this container and already has fluid in it. You will use that syringe to fill up this water seal chamber. Okay? This water seal chamber usually has a little blue dye in it, so you can tell the color of the water and the level of it. Okay? The numbers, this is where you're going to measure how much output is coming out of the patient. Okay? This tube is connected to the tube that's connected to the patient. This tube on this side can be connected to mechanical suction if the doctor orders mechanical wall suction. Okay? So this can be just normal Pleurovet, regular suction, or it can be connected to mechanical wall suction. It's going to be per the doctor's order. Okay? Now, having said that, you're the nurse caring for this patient. They came back to you. They just got this chest tube placed. You're going to monitor that drainage every hour to see how much is coming down. You're going to monitor it and amount, and you're documenting it in the eye and nose under the chest tube drainage section. Okay? You're going to mark this set every hour with your initials and time. Okay? And your document. Now, having said that, color consistency and amount. This water seal chamber, it's going to have a normal rise or fall. We call that tidal. And that's just the patient's breathing. Okay? If the water in this chamber starts bubbling, that could indicate an air leak. Okay? Coming from the side of the patient. Okay? So those are things you want to remember. You'll always keep the chamber below the level of the patient's thoracic cavity because you don't want any backflow. And you'll always make sure that, because the tubes are long. You can't tell on this picture, but they're long. You want to make sure the tubes aren't pinked. Okay? You want to make sure they're looped and not pinked so that the drainage can flow out. Okay? Putting a chest tube in allows a compressed lung to re-inflate. And it gets the drainage out. Okay? Now, that water seal chamber is going to contain 2 cms of water. That syringe has 2 cms of water, but it's up to you to check every shift to make sure it maintains that level. If it goes down, you'll need to add a little bit more. Okay? Water suction uses 20 cms of water again to aid in the drainage of air and fluid from the chest. Dry suction is that mechanical suction again, and that will be ordered by the doctor. Now, comes back to you, and there's 70 mLs of drainage out in 1 hour at any time. That's why I say you have to monitor it and measure it every hour and mark it. If at any time there's greater than 70 mLs out in 1 hour, you need to call the doctor. Okay? 70 mLs. And you want to replace it when it gets full. If it's getting to the full mark, you want to replace that collection chamber. And all you have to do, you have a connector that you connected the tube from the chamber to the patient's tube. You'll disconnect the tube. Okay, you have to clamp the patient side and clamp the tube. Disconnect it. You'll have a breathing collection chamber. You'll connect it to the patient side, patient's tube. Okay. Now, should the chest tube come out on the patient's side, you have to cover it with a 4x4. You would tape it on 3 sides if there's an air leak, because you want to leave one side open for venting, okay? Because you want that air to come out. Let's answer this question.
You said over 70 mLs per hour, right?
Yeah, but
Okay. Vigorous bubbling.
Okay. So I said several of you did.
502, 502.
Okay. Just show the answer with your hand, with your fingers, okay? Got it. That's correct. Okay. 2, 4, and 5.
502. And
That tracheal deviation should be a pneumothorax. Yeah.
question, so for
You wanna go back?
the 90, it has to be 95% for the oxygen patient.
It should be, because they're already on OT. So they're on 2 lanes at 90%.
Okay, so when that goes down, you still will need to call the doctor and let him know that oxygen is down? Or do you just go ahead and do anything else?
Well, they're remember, they're already on 2 liters. You don't have an order for extra, okay?
Okay.
So in nurse, we can only get 2 liters O2 without the water. We need more without the water.
before, you can't raise it up at all and then notify within 15 minutes or nothing?
Let's answer this question.
I know for COPD, no. Four.
Okay, so remember what I said, slash the trash, stay within your scope of practice, and your correct answer is 4. Because you can't do any of those other things that are outside your scope without a water, okay? Pneumonia. Pneumonia is the inflammation of lung tissue causing consolidation and exudate, okay? It can be bacterial, viral, fungal, or even aspiration pneumonia. It could be community acquired or hospital acquired. So when a patient has pneumonia, if they need to be placed on a ventilator because they cannot breathe for themselves, we do that protocol, ventilator associated pneumonia protocol, okay? And what we do is we do that mouth care every shift because what grows in the mouth?
Bacteria.
And the patient can't do it for themselves.
Yeast.
Okay? You're going to suction your patient that's on the ventilator and make sure that you hyperventilate them before you suction. Okay? Now, is there a vaccine for pneumonia? Yes, the pneumovac. Okay? And it could be the risk factor. You have elderly patients greater than 65, maybe patients that are living in long-term care homes, patients that have had recent abdominal surgery, because generally it's going to hurt to cough, it hurts to deep breathe, okay? And when they're not doing that, that exudate consolidation can build up in their lungs, okay? Patients that are comatose, altered consciousness, alcoholism, head injury patients, seizures, patients that have had strokes, okay? We consider these high-risk categories that we would give them a pneumonia vaccine, okay? And also patients that are immunocompromised. So, children, young children older than 2, and adults 65 years and older. We consider those, depending on the circumstances, high-risk populations. Okay? Now, influenza, if they're getting that pneumo vaccine with this group we talked about, yes, we want them to get that flu shot annually. Okay? But we do recommend that for everyone. I talked to you about that ventilator or that VAC protocol. Meticulous hand hygiene is also included in that. Okay? Now, that routine peptic ulcer prophylaxis will give them that because of what they're not eating. Okay? But their stomach is still going to build up that acid, and we don't want any ulcers occurring. Okay? And then we do the sedation and the weaning protocols. Patients without ventilator, usually, if they're not already in a comatose state, we put them in a chemically comatose state. The medication we use is propofol, okay? And when we wean them off, as we're turning it down, the patient can wean off from it pretty quickly, okay? And then once we get them weaned off, and they're extubated, we get them up, moving, walking around, coughing, and deep breathing. So early mobilization protocols are implemented, okay? So what you see here on this X-ray picture, we call it white bone, okay? Exudate and consolidation. It can cause tachypnea, productive cough. It's still pneumonia, okay? Dyspnea, tactile firmitus, okay? Mental status changes, crackles, decreased breath sounds, dullness on percussion, and ABGs that are indicative of hypoxia. Okay? Now, again, hand washing is always key to prevent infection. We're going to encourage fluids. The patients may even be isolated if the doctor orders isolation for the patient. Okay? We will give empiric anti-infectives as prescribed, those antibiotics. Okay? And we're going to manage the pain. But key thing, like I said, cough, deep breathe, okay? Turn, O2 sat, okay? We're checking it. We might even need to give them humidified oxygen depending on how much oxygen we have. All right? And then, again, that incentive spirometer, because that positive pressure, if y'all doing those selfies with pursed lips, that positive pressure is going to help what? Open up those alveolus that have possibly collapsed because all the mucus and fluid. Okay? So you get that with the incentive spirometer, coughing and deep breathing, and also you can teach them pursed lip breathing. Okay? You had a question?
When they say that phrase, dullness on percussion, what is that? Can you describe that?
We don't talk on work, okay?
Okay.
Because I'm going to explain it.
Okay.
It's just the word dullness, and then when you percuss, and I'll show you how to do the technique.
Okay.
Penicillins, anti-infectives. Okay, we have anti-pseudomonal penicillins. We have tetracyclines, aminoglycosides. Vancomycin falls into that. nephrotoxic. We said vancomycin for the kidneys, right? Gentamicin can be what? Ototoxic to the ears and for the hearing, right? Cephalosporins are also given for pneumonia. Macrolides, like erythromycin, and then the fluoroquinolones, which is the ciprofloxacin. These are just a few of the anti-infectives that are given for pneumonia. Let's answer this question. So earlier I said, when in doubt, take it out. Think about the lung, think about the anatomical position. Here, post-op, we had a left pneumonectomy, okay? So they had a left pneumonectomy, left lobe removed of the lung, okay? They're lying on their right side. So it's nothing on the left, that's the surgical space. They're lying on the right side, okay? And so the PN assesses the respiratory rate at 32 breaths a minute, so no, they're in some type of distress. Okay, so you want to measure the O2 sat and assist them into a supine position, because if they had a pneumonectomy, they have a chest tube to drain that fluid out. But if they're laying on the right side, all that fluid is doing what? Compressing the right lung. Okay, so we're going to change that position. Okay, and then of course elevate the head of the bed and administer some pain medication. Okay? What else does morphine, if we administer morphine, what else does morphine do? Why? Go ahead.
I just had a question, why wouldn't it be two first? Why wouldn't you change their position before mentioned?
You want they're breathing fast,
Right.
okay? But you want to check the O2 sat, see if they're compromised.
Okay.
Because it could be from pain. But when you check the O2 sat, and you say, okay, this fluid is probably compressing, not able to breathe, that means that right lung is getting compromised because the left one's gone. Okay? I heard morphine decreases respiration, but what does it do? It relaxes the smooth. Okay? And it also helps relax the patient. When we're looking at asthma, we said this morning asthma is an acute condition. We can correct it if we find out what the insult is. Okay? It's a chronic obstructive pulmonary, COPD consists of two different disease processes. Okay? We know asthma is reversible, COPD is not. Okay? It consists of chronic bronchitis and pulmonary emphysema. Now, some causes to COPD: smoking, occupational exposure, genetic predisposition, just to name a few. Chronic bronchitis, the pathophysiology of it. Chronic sputum with cough production on a daily basis for a minimum of 3 months to a year. That is chronic bronchitis. Okay? Chronic hypoxemia or pulmonale, increased mucus production, increased bronchial wall thickness. Exacerbations are usually due to infection. Okay? Increased CO2 retention. That's why we were talking earlier. Somebody asked a question. You don't just, if a COPDer is on O2, you don't automatically increase it. Okay?
I think the maximum is 2 years.
Well, yeah, but the doctor can increase it though. Okay? But again, there's CO2 retainers. So if you increase that oxygen, they're going to retain even more. Okay? Emphysema. When you see that barreling chest, that is because they're doing so much work for breathing over time that the chest wall and the muscles in there, they start to expand to compensate for that. So that's where the barrel chest comes from, okay? Emphysema is an abnormal enlargement of the air spaces distal to the terminal alveolar walls, okay? So there's that increased work of breathing over time and increased O2 consumption. So again, bronchitis and emphysema equal COPD, right? When you're inspecting, the person with bronchitis might have right-sided heart failure, cyanosis, distended jugular veins. Okay? Now with emphysema, pursed lip breathing, you'll see them doing that to try to get air in, and they're usually non-cyanotic and thin. Have you all ever looked at the mnemonics or the pictures of the pink puffers and blue bloaters? Some of you say yes, some no. If you Google that, it's such a great memory tool, okay? Now, Elsevier is not promoting the mnemonics books, but if you look at a person, it'll have emphysema over the top in real big letters. And then it'll have someone that's doing this pursed lip breathing, if you've seen it before. And then they're non-cyanotic and thin. They're pink puffers. And their bronchitis are the blue blowers. Okay? It's just a memory tool that helps you to remember those signs and what symptoms. Okay? Now, bronchitis, when you're oscillating those lungs, you're going to hear crackles, bronchi, inspiratory and expiratory wheezes. Emphysema, you're going to hear distant breath sounds because what? Barreling of the chest. Okay? You'll also hear quiet breath sounds and wheezes. So with COPD, you want to keep the O2 sat greater than 90% during rest, sleep, and exertion. Okay? Or a PaO2 greater than 60. Now, we already talked about long-term continuous oxygen therapy. And that is any COPDer that's using oxygen for more than 15 hours a day. Okay? They classify as LTO, long-term oxygen therapy. Okay? Now, you want to monitor for signs and symptoms of fluid overload. We're checking those baseline ABGs for the CO2 retainers. And some other key things you can do as a nurse is teach them that orthoptic position. Okay, that's what you see on the screen. When they're leaning over, it gives the chest more area and space so they can get more air in. Okay? Called the orthoptic position. Let's answer this question. Now, the correct answer is no. The correct answer is no. It reflects respiratory acidosis, indicating respiratory failure. Now, this picture, I really like it because it really explains, it shows you the swollen mucosa and it shows you the mucus inside of the swollen mucosa. Okay? How is air possibly getting through there? Okay? If it's an asthma exacerbation, guess what? It's not. Okay? So, it can be called, remember we said asthma is reversible, so we need to find out what's the result. Okay? So it can be caused by allergens, cold air, environmental irritants, exercise, beta blockers, respiratory infection, emotional stress, and reflux esophagitis. So, having said that, it's medications that we use that we call rescue medications, okay? They can be in inhalers or nebulizers. Can y'all name me some of
Yes,
those
who is-
rescue
can I help you
medicines
to say
for
again?
asthma? Albuterol,
Yes, who is this?
steroids are
Hold on a second.
not so much rescue. They're long maintenance, epinephrine, okay? One, albuterol, epi, just to name a couple, okay? Now, what are some of those long-term maintenance meds? You also said what? Steroids. Okay. So this is a gentleman in the picture using his meter dose inhaler. Let's just say it's albuterol. He is using a spacer. The spacer helps him get all of the medicine, okay? Rather than just using the meter dose inhaler in his mouth, okay? With his mouth, he can only get one inhale, but with the meter dose inhaler, he can get several because the medicine is trapped in the spacer, okay? Yes.
Kind of off topic, but is that a new thing? Because I just remember when I was younger, I never saw that spacer thing.
It's not.
I never had asthma or anything. I just never saw anybody use it.
My youngest, who's 22, he has asthma, and he had his little spacer. So, yeah, it's not new. It's just, the thing about it is, what can I say? When they first started making them, they were extremely ridiculously expensive, and it made no sense.
Or maybe it's all the movies. I saw the kids. Nobody ever had a meter dose of meter.
Yeah, well, yeah, the spacer is separate from the meter dose inhaler. You have to purchase it separate.
Tell my daughter, we had to get a prescription from the doctor for her to have the spacer.
Yes, remind you to, yeah. But it really makes a difference.
Is the spacer, does that have to be replaced, or is it like, is it like a yearly replacement type thing, or is it
No,
just?
as long as you take care of it and keep it clean and dry,
Okay.
it lasts.
Okay.
My child's been there. Because when he felt bad, he knew I feel bad, and this helped me much better than just using the inhaler. So he was very meticulous about his little space. And it was for kids, they have little teddy bears on them and stuff, okay? So, but anyway, when you have a patient, them using that versus just their meter dose inhaler, after you nurse it for a while and you're listening and auscultating, you can tell the difference. Like with your daughter, you can tell
Yeah.
with the spacer. Yeah, it's very different because they get all of the
Because she would want to just let it out of her mouth, and try to get her to hold it in, how they kind of made it like a game. I think hers had a teddy bear.
Yeah, little yellow, it's yellow, and have the little yellow teddy bear. You know about that little teddy bear. It works for kids, I tell you, it makes them want to keep it around and use it. So, COPD medication goes. Oh, our long-term control medications. We have medications like what? Singulair, Advir. Those are some of the long-term medications. Some of them have the quick-acting plus the steroid in them, okay? So they can work together. With COPD, the goals, we want to reduce COPD exacerbations. We have the long-acting beta agonist. We have an intercostal space inhaled corticosteroids, okay? And we're looking at these bronchodilators, okay? These are for asthma and COPD. So we have the short-acting, long-acting B-adrenergic agonist, and we have the anticholinergics, the inhaled anticholinergics like, let's see, ipratropium, that's like Zopinex, okay? Y'all ever heard of the Zopinex? It's called ipratropium. So, short acting, we already said, some of these, you have them by nebulizer, elixir, meter dose inhaler, salbutamol, we talked about that, sulfate, nebulizers, oral tablets, this just to name a few. Levobuterol could be given nebulizer or meter dose inhaler. They could be administered different methods, okay? So you have the inhaled long-acting. We talked about some of those already. Salmeterol, it's the dry powder, okay, form. Now, I'm using these generic terms, but you all probably know it as Advir, okay? And we also have immediate acting, like we said, epinephrine, okay? And the corticosteroids. So again, you know what lung sounds are gonna sound like. If you have a patient that has asthma, you've got the mucus production, they're gonna be wheezing, they might be dyspneic, chest tightness, okay? You wanna know what medications they're on, their med history, and determine the need for ventilatory support, okay? If they can't breathe on their own, they will need to be on a ventilator. Collaborative management, you're monitoring levels of control, okay? When I say levels of control, can anybody tell me what a peak flow meter is? Yeah, I heard somebody saying it low, but then you blow in.
Oh, I'm thinking.
Oh, you did too,
Thermometer? That was for the asthma, right? Is that wrong?
It's for the lungs. It's sort of like a pocket pulmonary function test, but I'm just gonna put it low level, very low level. Okay? You want to tell us what it is? So the peak flow meter is a little machine. The pulmonologist is gonna take it. Did you say it over there? I can't hear.
Is it to see like there's like a red level, green level, and yellow level to see how much air they can get rid of, and if it's below a certain percentage, you need to up their medication or give it to them right now
Yes,
for
exactly.
pediatric. We had it in pediatrics.
Okay, yeah, that's exactly what it is. They use it for children and adults, okay? And if it's in the red level, you wanna call and let your doctor know, or the doctor will have already given you instructions on what to do if you get in the red zone. If you have a nebulizer, you may need to do a neb treatment, okay? After you finish that nebulizer treatment, then check your peak flow numbers again, okay? Now, having discussed all of that, pulmonary tuberculosis. TB, okay, is a communicable disease. It's caused by Mycobacterium tuberculosis or the tubercle bacillus, an acid-fast organism spread by airborne transmission. There's primary infection, which is bacterial or inhaled, and then there's latent TB, okay? Of course, the immunocompromised are at higher risk. Multi-drug resistant TB, the disproportionately in poor, underserved, and in minorities, there's a higher risk factor. And then underserved working institutions, there's a higher risk factor. When we're talking about TB, we assess for TB, look, if y'all are nursing students, we do the what? TB skin test, okay? Some people cannot get the TB skin test because they know they will always be positive. People that have come in contact or had TB before, or what other group? What else could it be related to? The BCG vaccine. If anyone has had the BCG vaccine, they will always have a positive skin test. And they know this, so they tell someone, they tell their provider, I will always need a chest x-ray. Okay? It's a BCG vaccine that was given in other international countries. Okay? And it just automatically, the patients will have a positive TB skin test. Doesn't mean they have TB, just they're gonna react to the TB skin test. So if a patient has TB, we are going to isolate them, okay, if they're in a hospital setting or clinic setting. We're gonna have them wear the HEPA mask filter, okay? Sputum specimens will be collected, and we're teaching them to cover their cough and their sneezes, okay? And negative pressure room, okay? That's the standard. First line drugs. INH, rifampin, ethambutol, rifabutin, and pyrazinamide. With these medications, you want to explain to your patient the side effects, okay? So you can see some of the side effects up here, but GI symptoms is one of the main side effects for these medications, okay? So you want to prepare your patient for that. Now, strange side effect is it does turn some of the body fluids orange. It turns them like rifampin, discoloration of body fluids, sputum, urine, sweat, and tears. It turns orange. Okay. Ethambutol, it's decreased red-green color discrimination in what they see. So their color perception, they might have a decreased perception of the colors red and green, okay, with Ambutal. And then, of course, orange body fluids with Rifabutin. So, management, 8 weeks of INH, rifampin, ethambutol, and PCA. Then, after those 8 weeks are done, they're going to follow up with 18 weeks of INH and rifampin only. Okay? Let's answer this question. Okay. So, the correct answer is BCG. Okay. The BCG vaccine. So I didn't want to answer you before we did the question. So again, now clients will need to have a chest X-ray and avoid the PPD screen for at least 2 years after administration. Okay, so a lot of patients do not. Now, PE or pulmonary embolus, it's a substance that can cause an embolus. Okay, it can, and then if it does cause an embolus or clot, it can pulmonary vasculature and cause a PE, pulmonary embolus. Okay, risk factors for PEs are patients that have been immobilized for a long period of time. Okay. It's also patients that may have had central venous catheters. That's a risk factor to getting a central venous catheter, like a central line. Surgery in the last 3 months. Okay. Obesity, malignancy, clotting disorders. Maybe they had a history of thromboembolism or DVT. Okay. Smoking, birth control pills, pregnancy, and heart failure all can be a risk factor to pulmonary embolism. So if a patient has a PE, okay, usually they're going to say, I've had a couple of patients with PEs. The person came back from a thoracentesis. When we got it back and situated, he was watching TV, and all of a sudden he sat up. I had gone in his room to empty his urinal. And he sat up and he said, I feel like I'm going to die. I could actually see the color draining from his skin. Okay? I pushed the cold button. Everybody rushed in. And within seconds, I felt his getting cold, clammy in my hand. And you know, we had to get a flag crash cart because he went out. He was non-responsive. Just that. Okay? So, you're checking for everything. You're monitoring those vital signs. You're doing, you're listening to heart, lung sounds, okay, anterior and posterior. Because when he started breathing, I kind of could hear, you know, the stridor. And I could tell, okay, he's losing oxygen.
Were y'all able to save him?
Huh?
Were y'all able to save him?
Yeah, we were. They took him back to surgery, okay? They were able to do an embolectomy, but they put in a vena cava filter for him, okay? And that's one of the treatments you can do. He had other clots, so that vena cava filter, when clots try to pass, that the filter catches those clots. And you start off with heparinization, okay, because you want to get that blood as thin as possible. And then we put him on Coumadin about 2-3 days later, okay? And then we wanted to get his levels within the therapeutic range. And I'm probably getting ahead of myself, but I'll talk to y'all about that. Getting his levels in therapeutic range so that he can go home. We can stop the heparin and he can go home with Coumadin, okay? To keep his blood thin. But that vena cava filter is put in to stop the other clots, okay? Now, You want to do range of motion exercises, so everything you're teaching your patients in the post-op period is so that they won't develop clots and won't develop them. Okay? They won't develop the post-op pneumonia. So, if they have a history of clots or DVTs, you will not massage the lower extremities. Okay? No massaging the lower extremities. They won't use SCDs. They need TED holds, okay? Because SCDs are what? Massage. They have that rhythmic massaging motion, okay? They'll need TED holds. If they're traveling, you want to teach them to take breaks, stop at rest stops, get out and walk. If they're flying, they need to walk back and forth to the bathroom on an airplane a few times if it's a long ride. And if they smoke, encourage them to stop. So yes, like I said, we're doing ABGs, we're checking vitals and lung sounds and the cardiac status. The doctors will do an embolectomy, and again, that vena cava filtration, replacement of a vena cava filter, okay, can be placed. I talked to you all about the anticoagulants when I was telling you about my patient case. Coumadin, like I said, is initiated within the first 3 days of heparinization, and then it's continued for 3 to 6 months. When we look at the PTT, when I talk about getting it to a therapeutic level, we want it around 1.5 to 2.5. Okay, that's where we want that PTT value. Now, when we're looking at anemia, there's always a problem for it, okay? What are causes? It could be iron deficiency, decreased erythrocyte production, decreased hemoglobin synthesis. It can be from chemotherapy, blood loss. It can be from bleeding hemorrhoids or menorrhagia, where women have heavy bleeding menstrual cycles, okay? These are just even trauma. So, when you're doing your assessment, you're assessing for skin pallor. You're going to ask them if they're easily fatigable. Okay. You want to ask them about their cycles. If it's a female, is it normal? Okay. For men, if you might want to do a gastrocult, okay, to see if there's any bleeding in the stool. And you're going to do, of course, complete blood counts. You're going to encourage a diet, folic acid, B12. If they have GI disorders, and especially if they've had a gastric bypass, they'll need to take B12, okay? Now, iron, for iron deficiency anemia, you'll replace the iron. If you're going to give an iron injection, you're going to do it by Z-track method, okay? The only reason is for that is because it causes a dark discoloration of the skin, and you don't want that. So you'll displace the skin, okay? And then you'll do your injection, and then you'll place the skin back, okay? And it just makes a little thicker area so that there won't be that dark skin discoloration. And if their blood is low, of course, the RN will do a blood transfusion. Okay? Let's answer this question. Yes. Okay. So right answer is 3. We're going to stop that blood transfusion and notify the charge nurse. Okay. Now with hypertension, it's a blood pressure, persistent elevation of 140 over 90. Okay, over multiple reasons. Some risk factors, genetics, family history, ethnicity. Modifiable, those are non-modifiable. Modifiable are smoking, okay, alcohol, tobacco, caffeine, sedentary lifestyle, and obesity. Now, other medications are diuretics, antihypertensives, ACE inhibitors, calcium channel blockers. Hypertension education, we want to teach our patients it's the #1 cause of stroke, and do not start and stop and skip hypertensive medication. If you do, the patient can get rebound hypertension, okay? The blood pressure can go up higher than it initially was, okay? So it's very important that they take their medication correctly. It can also cause them to have a CVA or a stroke. Okay? Coronary artery disease, again, is one of the leading causes of comorbidity, of morbidity and mortality. Okay, coronary artery disease. We kind of talked about that. The heart is the engine, it's the pump. Okay, if the patient has a heart attack, what? You want to get oxygenation back to that cardiac tissue as soon as possible. Okay, because if the cardiac tissue is without oxygen over 20 minutes, that tissue can die. Okay, so again, if they have atherosclerosis or partially or completely blocked arteries, there are different diagnostic procedures that can be done to assist. I'm going to get to that in just a second. But as the nurse, we can recommend the DASH diet, okay, and weight loss. That DASH diet is low cholesterol, okay, glycemic control, smoking cessation, stress reduction, medication compliance, and increasing their activity. If their cholesterol is elevated, we can start them on cholesterol lowering drugs. Okay? And this is just a few that are listed here. Okay? Most of the statins, but you also have medication like geparbazil, niacin, or even nicotinic acid. With angina, it could be stable, unstable, or we have the Prince metal. Okay? The stable angina is predictable, subsides with rest. Unstable, unpredictable, may not subside with rest or nitroglycerin. Okay? Now, the variant angina or the Prince metal angina, we look at that. Vasospasms are usually the cause. Okay? It occurs at rest. It can be precipitated by smoking or any other substance. Yes, the pain can radiate to the jaw, shoulders, neck, arms. Patient can get dyspneic, have syncope. But how do we treat angina? Nitro. How do we administer it? What are the directions?
Every 50.
Sublingual. Take one dose. Take it as sublingual. You're going to wait how long? 5 minutes. If it's not working, you're going to do what? Second dose. Same thing. How many doses can you have? Three. Okay.
But we call them after the second one immediately, or?
If the second one doesn't work.
Yeah, but I know. But I'm just trying to remember. Is it? Because I know sometimes she'll say like after if it doesn't work, then we call so it can be on the way. But then sometimes she'll turn around and say it as if like when we know we need the second one, go ahead and call right then. But as far as NCLEX wise, when they ask us that question,
They're going to ask you how to administer the medicine, and it's 3 pills, 5 minutes apart.
okay,
So you have to think about it.
If you take the second one and you wait 5 minutes and it doesn't work, only 10 minutes have passed. If you got to take that third one, take the third one, and if nothing's happening, call the doctor. That's only 15 minutes.
okay.
So we're not rushing it. You have to know you take 3 doses, because 3 doses after that might help the patient.
Okay.
So you're gonna follow those instructions, then call 911.
Then okay. Thank you.
Because it's a short period. It's not a long period of time.
Yeah, sometimes it can get confused on like when doing the lecture. It's like then the book is 3 and then call. So.
And that's the book read that. But some people,
Yeah.
better to go ahead and call, but
Yeah, because she was in time with the essence. I just wanted to make sure I didn't get confused.
follow the instructions on the medication.
Okay.
The instructions are going to tell you after that third dose, if you don't have any problems.
Okay.
Next, diet therapy. You can see your patients choose my plate.gov. And it's going to show them, like you see up here, the portions they can have, the amount, and the types of food for each portion. Okay? The DASH diet is going to, like I said, reduce their cholesterol and their triglycerides. gonna aid in maintaining ideal body weight, and their daily cholesterol intake should be less than 2. For angina, we also have the antiplatelets, which are aspirin and clopidogrel. Okay, these are just a few beta blockers, nitrates, anticoagulants, ACE inhibitors, and analgesics. We already talked about nitro. Okay, you do want to administer oxygen. Okay, nitroglycerin, it dilates the coronary arteries. Okay, it increases blood flow to the damaged area of the myocardium. 0.4 milligram tablet, 1 tablet sublingual every 5 minutes for 3 doses. Now, morphine, like I said, decreases anxiety, okay, and it relaxes those bronchial smooth muscles. That's what helps with that respiration. Okay. Beta blockers decrease the heart rate and the workload of the heart, thereby decreasing the oxygen demand of the heart. You have calcium channel blockers that decrease the conduction through the AV nodes, so the heart rate, decrease the oxygen demand of the myocardium. And then you have the thrombolytic therapies like TPA, okay? And they're most effective if they're given within 6 hours of onset, okay, of the chest pain. So that's why I say you can get that TPA within 6 hours of onset. If you're taking nitro, that nitro course is only going to go for 15 minutes. So take that 3rd dose, and if it starts working, if it doesn't work, call 911. Now, I said there's some interventions that can be done. I didn't want to get ahead of myself. This is, the first one is the PTCA that you can see. They can go in, okay, with a stick and open up the vessel, move some of that plaque around, okay? They may leave that stick, do a ballooning, okay, and leave the stick in place to keep it open, right? And this is what it can look like. But I had students just last week that went to the cath lab. They got to see a procedure, and even the probe with the stick on it would not go through. This patient had to be taken immediately for a stent coronary artery bypass, a catheter. Okay, and that is what you see up here. The other alternative if these don't work.
Now, you see on this picture that myocardial tissue, if the myocardial tissue is without oxygenation for 20 minutes, that tissue will die. It does not regenerate, it does not come back, okay? But the heart, the firing mechanisms of the heart, they're very smart and resilient. They can do a workaround, okay? Depending on how good it is, patient might get a normal sinus rhythm. But usually, 90 to 95% of the patients have some type of dysrhythmia. Okay,
maybe like atrial fibrillation, and those dysrhythmias have to be treated. Okay, so again, destruction of myocardial tissue happens due to lack of blood and oxygen supply to it. There begins the occlusion of the coronary artery, ischemia, injury, and infarction. Okay, that is the MI. There can be an ST elevation, which we call the STEMI. Okay, and then there can be a non-STEMI, but in the women, usually they have the non-STEMI. Again, I talked to why the ischemia happens, decrease in the blood flow, and then injury to the tissue. I already told you if it lasts 20 minutes or more, that tissue will die, okay? Sometimes you can see a T-wave inversion when that tissue dies because it's doing that workaround, firing mechanism of the heart. Now, infarction equals tissue necrosis and death, and there's irreversible damage with infarction, okay? Scar tissue has no electrical stimulation. That's why I said those firing mechanisms have to do a workaround, because that scar tissue, that dead tissue, has no electrical stimulation, okay? So, like I said, as many as 90% of clients suffer complications. I talked about the dysrhythmias. They can go into cardiogenic shock because what did we say? Cardiogenic shock, the heart is the engine, it's not working, okay? thromboembolism, they can start throwing clots because with those irregular heart rhythms, let's just say atrial fib. It's not that hard pumping force of the love duct, okay? And then fibrillation is sort of like a quiver, and that blood can start to pool in different areas and pool, as we know, pooled blood clots, okay? Pooled blood clots. Are there any questions about that? No? Okay. So, if that is the case, we're looking at signs and symptoms. Sudden onset, if they're having this myocardial infarction, chest pain, it's persistent for hours, it's not relieved by nitro if the patient is on nitro. It could be heavy constricted chest pain, okay? We used to say it feels like an elephant, people say it feels like an elephant is standing on my chest, just pressure, okay? This pressure is located behind the sternum. It may radiate to the arms, the back, the neck, or the jaw. The patient can talk about their skin, but again, it might start feeling cold and clammy, okay? And then they might have that rapid and irregular pulse. Like I said, women, discomfort, okay? They might have that non-stimming usually. Patients that are diabetic, usually are asymptomatic, they have neuropathy and usually present with dyspnea. And then we have the elderly clients. Usually they present with confusion because of oxygen deprivation and confusion and dizziness, okay, and short of breath. Now, what you see here, the first diagram is a stigma. You got the ST elevation, okay? The other diagram you see, those are the biomarkers, the cardiac biomarkers. Okay? If you've ever heard serial troponins when a patient comes in with chest pain, okay? All right, let's get some cardiac enzymes. That's what these are. Troponin, CK&B, and myoglobin, okay? The myoglobin, it spills out into the patient's blood as soon as the event occurs. It peaks at 5 hours and it lasts 15 hours after the event, okay? Now the CK&B spills out into the blood when the cardiac event occurs, peaks at 15 to 20 hours, and it dissipates after 30 hours after the event. But the troponin, okay, those serial troponins help all of these cardiac markers show us where the patient is in relation to when their event occurred. The troponin spills out into the blood at the time of the event. It peaks within about 20 hours after the event, and then it doesn't dissipate until 2 weeks later. It stays in the patient's system, okay, for 2 weeks. That's the troponin. That's why we space out those troponins, and we do about 3 over a period of time. And you're looking to see when it is going to kind of start dissipating. That'll tell us when it peaked, and it can tell us when it began, okay? The cardiac event. Now, to preserve the myocardial tissue, we talked about nitro, beta blockers, oxygen, drug therapy, morphine, and then the thrombolytic therapy, the stents, the ballooning. We talked about percutaneous intervention, coronary artery bypass graft, okay? And we talked about all of that. Now, it doesn't always have to be, bam, immediate emergency. A patient might be under their doctor, might be having some chest discomfort, okay? And go in, cardiologist sends them to get a cardiac heart cath, and what? They find a blockage. Maybe they put the stent works fine, okay? You just need to know the treatments, and as a nurse with this type of a patient, you need to know your assessment and what you're assessing, okay? Now, I talked to you already about the cardiac lab test, heart failure, okay? If a patient is having heart failure, there's some causes to that, okay? It could be coronary artery disease. Maybe that had a prior MI, okay? A prior heart attack. Chronic hypertension, cardiomyopathies, okay? thyroidism, diabetes, valvular and congenital heart disease, or pulmonary disease. These can be some of the reasons. Okay? So, you want to make sure you know the difference. Left-sided heart failure and right-sided heart failure. Okay? I'm going to give you some key things to look at so that you'll know the difference between the two. Okay? With left ventricular infarct, you can have cardiomyopathy or hypertension can cause it. With right-sided heart failure, it can be caused by left-sided heart failure. Okay? So you want to know that. It can be caused by pulmonary or tricuspid valve disease, pulmonary hypertension, COPD, or PD. This is right-sided heart failure. So these are some things you need to remember. Now, left-sided heart failure, some of the symptoms. Bless you. Dyspnea, cough, orthopnea, pulmonary edema, nocturnal dyspnea, shortness of breath at night. This is left-sided heart failure. Systemic congestion with right-sided heart failure. Dyspnea on exertion, fatigue, weight gain, and fluid retention. This is right-sided heart failure. So, signs, other signs with left-sided is 3 gallop, tachycardia, and inspirational rounds. Okay? Other laboratory findings. ABGs will reveal hypoxemia. Chest X-ray will show pulmonary edema, and this is left-sided heart failure. Okay? And then with right-sided heart failure, jugular vein distension, hepatomegaly, ascites, peripheral or sacral edema, and pleural or pericardial effusions. Okay. I'm going to let you all take a quick break, 10 minutes. Be back at 10 after. We'll finish this chapter and go on to the next.
What chapter we stopped at today? What chapter did we stop at today?
We should stop at 6.
They've been showing those little,